Dr. Girma Tefera here with us this morning. And he is, you might recognize his name from several conversations we've had within the department because he has been instrumental in helping us develop and grow and really kind of vision what global surgery is, how it fits into the context of our ecosystem here at UTHSC, but also globally, if you will. Dr. Tefera comes to us from Wisconsin. Looks like a beautiful day in Madison this morning. He is a trained vascular surgeon and a leader both in his field of vascular surgery as well as global health and academic global surgery. More than 100 publications, more than I can mention right now. Just know that he has played a leadership role both within academia, within vascular surgery, as well as global surgery specifically. He's currently the director of Operation Giving Back and has been in that role at the American College of Surgeons since 2015. He's done numerous presentations for all levels of learners, both locally here in the United States as well as internationally. And for all of that work has received several, many accolades with regards to that work. So we're so excited to have him here with us this morning. He most recently, if you've been looking at the American College of Surgeons activity, most recently has been responsible for envisioning and deploying a multi-institutional training center in Ethiopia for surgeons for the region. So honored. Again, thank you for being with us today as our Global Surgery Visiting Professor. And thank you to our deans, Dean Witt, Dean Strom, not sure if he's on here just yet, our Executive Dean, Medical School, and Dr. Shibata, of course, for allowing us this opportunity. Thank you, Dr. Tefera.
Thank you, Nia, for that nice and kind introduction. I will momentarily share my screen, and yes, we have a beautiful day in Madison. I think we started off with a temperature of 24 degrees Fahrenheit, and I think we're going to warm up to probably 28, so it's a beautiful day. So let me share my slides and get my presentation going here. Can you see my presentation?
Yes.
All right. So thank you, Niajo. First, I just want to, for those of you who don't know how much work Nia has been doing for global surgery the last couple of years, I just want to mention that she has been one of the central pillars of forming an association called the Association for Academic Global Surgery. That is something that, conceptually we started thinking about it in 2017. And for 2 years, it has been relatively making very small baby steps. But after she jumped in about 2 years ago, with 2 other colleagues, the 3 of them have been really leading this charge to form this organization that this past year, most of the foundational work has been done. And hopefully by the end of this academic year, we're going to have officers and defined memberships and so on and so forth. And so this is really a historical moment for academic global surgery. And she has been really front and center in that. And I really, really appreciate the amount of time and energy she has put in there. So yeah, thank you so much. And I'm sure we will all be proud when we see what this organization is going to do for academic global surgeons in a few years, because right now we are just rising, and hopefully our population is going to increase, and will definitely make a huge impact worldwide. Not to say that we're not making that already, but I think the part that we are really working on is are we getting the recognition, and our global surgery faculty, are they getting what they what they need from their academic output perspective? And I think that is in the making, and everybody's staying tuned. And And please join us in the efforts, because it's really, really important that we see outwards, that we see pupils and populations that are underserved. And I know, and as you know, NIA has been dedicated to really providing service to the underserved for years and years. My goal today is, very specific. I just want to give a few additional dimensions to the global health work we do, at least for the residents, and if there are students, also younger faculty who may want to jump in. And I just want to make more of you think about public health, because as surgeons, we have been really way, way behind. And global health, is considered, something that only general surgeons do. However, everything we do is actually an important public health contribution. And I want people to think that way. And hopefully for some of you, by the end of the day, by the end of this talk, you'll start thinking about it. What we do in surgery when we go into the international realm, or even locally in our underserved communities, is actually a major public health activity. And in fact, when we see from publications clearly, the work we do across the globe is sometimes even better than providing those vaccinations, which everybody thinks it's a public health work, right? So there are a lot of disease burdens that we want to touch on. And most of you know, since 2015, there has been a lot of focus on surgery, and I'm sure a lot of publications around the global surgery burden. And I'm not going to throw a lot of numbers at you, but there are some few important, informations, however, that I need to share. I think it is important for those young ones who are starting early and wanting to really know how to develop partnerships. Maybe there are things we can share, and I just want to share both my failure and successes, so that maybe with the question and answer sessions, we can make even more clear that topic. I also want to add a little bit more dimension to the global health discussion beyond surgery. And so that's why I chose the topic that this is not really only about surgery, it's a lot more than that. Before I really dive into the discussion and the conversations, I have this slide here to show you when we do global health, it is not, it's not a one-person show. It is really a lot of people working together. And it's really an amazing teamwork. It's a teamwork within, and also teamwork from the other side that we are partnering with. So this basically family, every year, you do global health work increases. And it's really a joy to, look back all the different friends you have, met, and also the cultures you have, learned, and so on and so forth. So I just want to give thanks to my global health collaborators, particularly from the University of Wisconsin and also from Addis Ababa University, because some of the work I'm going to describe really centers around that. So I know this is, a time of COVID, and, we have not been traveling. However, we have all gotten also very creative, right? And come up with so many online solutions to really stay connected. And actually, our connections are even more stronger. In fact, we connect by Telegram, we connect by Zoom, we connect by WhatsApp, and the amount of lectures and exchange in ideas and knowledge has actually continued. And not only that, the family of individuals, or the family of global surgeons who want to participate actually has increased. And I hope it's the same at your institution, because now you really don't have to travel to be a global surgeon. You can do it also from your institution. The lectures you can give, be it a grand round or a journal club you can, host with an institution way up in sub-Saharan Africa or in Far East Asia, is equally important. And so I think I think the requirement of travel is no more an excuse. And so, so this is really an opportunity where our group, our membership has widened. So, I just want to get started with this slide because this is basically the era we are in. The United Nations in 2015 has adopted this agenda where they have created an outline, if you will, a blueprint for bringing peace and prosperity and health across the globe. And they have identified 17 goals. And these 17 goals are, basically the core of what we call now the Sustainable Development Goals. And goal number 3 is something that is really focused more on health. But as you can see, everything contributes to health, right? So, be it, the poverty, or be it education, be it the environment, water and sanitation, everything is actually interconnected. And so you can sometimes look at these 17 goals, but with the health component right in the middle. And this connectivity therefore makes it really important as we dive into the global health arena, that we need to learn and understand what all these other development goals are, so that our contribution can have significance. And believe me, as surgeons, we can understand easily, we can actually do things. I mean, we are very effective in doing things. And so we should be very much into this without, being, limiting ourselves. And in fact, a lot of other, healthcare providers, be it pediatricians or, obstetricians, have been public health officers for many years. They are probably 25 years, ahead of us. And I think we are catching up pretty quickly. So I want to pick a couple of these, development goals so that we can really see those additional dimensions, if you will. So the first one is, is to end poverty, and as poverty is everything, right? If you are poor, you're going to have a poor health. If you have a poor health, you're going to be poor. I mean, this doesn't need a lot of explanation. And this is definitely a lofty goal. This, goal is also, when you look at it, we're talking about, increasing the population that earns more than $1.25 a day. Actually, I think they raised it to $2 now. But remember how, think about how small that amount is and how much of the world population actually is still living in poverty. In fact, COVID is not helping. Even in 2020, as we speak, 71 million people have been pushed further into poverty. And so one of the things as surgeons we have to think about is clearly, the poverty piece is the weakest link we have in improving health in general. So unless we think about it, unless we solve it to some degree, it is not. And this problem is also in the US, right? It's not only in sub-Saharan Africa. It is everywhere in the globe. And so one of the things that people always think about is aid, and aid has been there for a long time. And about aid, when we talk about this to solve or resolve issues of poverty, it is something probably people have been doing more of since the Second World War. And when we look at aid, for those who want to really learn a little bit more about it, I just recommend, this is a very quick read. And it is written by an economist, actually. She is originally, I think, from Zambia. And this will really tell you how aid is not working for those poor countries. It is important, therefore, to know and understand why it is not working. And in fact, what this author here discusses is that aid, for most part in Africa, has removed, some of the link between accountability of the politicians to the populace, and thereby created actually more corruptions, and there are distorted market practices that is actually leading to even more poverty as we speak. And in fact, when I looked at the different aspects of aid, as you can imagine, over the past many years, people have been sending food to Africa, as you know, and the amount of grain, the surplus food that is sent from the US is incredible amount. But do you think that is helping? If you really think about, is the best way of helping a farmer by giving them food? Is that what it is? And that's what happens. And so we need to really understand these issues to also figure out why actually aid is not working. And in fact, to my question, why are farmers not being helped with mechanization? Why are they not helped with storages? What an interesting answer I got from an honest, person who works in an NGO is, well, I don't think we want to work ourselves out of a job. So you can imagine sometimes how the philosophy behind this aid is really not honest. It's not effective. And in fact, if you want to understand more, if giving more money, is it really, solving the issues? Just read this book. This book will tell you the story where, the incredible amount of money that has been raised to help and support Africa and countries in Southeast Asia has not been working. In fact, Africa has lost self-sufficiency. 7 out of 10 Africans are at the verge of poverty. So things like COVID is going to push them over the edge, and the infant mortality rates are increasing. And despite the billions and billions of dollars, GDP continues to fall. And so the way aid is being provided now, it's not working. And one thing that we also know after the Second World War is this famous plan that worked in Europe. And when you look at this plan that worked in Europe, which is the Marshall Plan, it is really interesting how the US provided about $20 billion post Second World War. And there were few recipients of this aid, including the Great Britain, France, countries like Italy, Austria, Greece, the Netherlands, and so on and so forth, and see where their economies are right now, right? And one of the real important distinctions why this worked in Europe was because the money was actually put on infrastructure development. It was not something that went into the budget of the government. It actually built something, the infrastructure, so that the population could get back on their feet and be productive again. When you look at types of aid, actually, there is a humanitarian or emergency aid, which comes after disasters like tsunamis or hurricanes. But most of the aid these days is a systemic, direct government-to-government aid transfer, and according to my readings and according to a lot of publication, it is really not working. And we have to really learn a lot from that. And in fact, the goal to actually resolve the issue of poverty by 2030 is not on a good track right now. It's going to be a huge challenge. The third sustainable development goal that United Nations have approved is really good health and well-being. And here is where we come, right, as surgeons. And this is a picture that I took when I went as a visiting external examiner to Ethiopia many years ago. And there were 8 patients that the final year residents were examined on. And if you look at this picture up here on the right hand side and up, it's a bladder extrophy in a 19-year-old person. Here is a big sarcoma of the thigh. And I don't even know what kind of tumor this might be on the neck. So what this tells you is we can do whatever we want to do in terms of trying to go and help with surgeries and so on and so forth, but we are not going to solve this issue unless we think this through, from a much broader, wider angle of strengthening the system to identify these things early, and also train their own, physicians and nurses and others, so that detection of problems and taking care of these problems earlier can happen. And so this brings really the discussion around the healthcare delivery in general in the developing countries to a point where, is it the resource issue or is it shortage of workforce? And in fact, the shortage of workforce is the #1 issue compared to the material and resource shortages. And so I think we need to know about that as we get into global health and global surgery. And in fact, over 500,000 women die at childbirth because of lack of healthcare actually providers. And the amount of healthcare providers in sub-Saharan Africa is just only 3% when the disease burden is about 25%. So there is all these disparities. And on top of that, there is this onslaught of migration of professionals out of those countries that are developing. Clearly, this is an individual right. People have the right to migrate, travel, and so on and so forth. But it is also a complex problem. And I'm not going to judge anybody because I'm also a result of migration from my country, which is Ethiopia. But this is actually a global problem that, as global health professionals, we need to think about and think through. And in fact, when these people migrate, where do they go? They go to these top countries here. And in the US, we have 27% of our physician workforce is actually foreign graduates. Think about that. And so this has become very addictive actually for developed countries. And this is one dimension we all need to think about in a way that as we look, in general about aid and in general about, workforce development and health, where we are is not acceptable. It's not acceptable that 33% of the African scientists are gone and 27% of the physicians in the US are foreign graduates, and most of them coming from this developing countries. So I think as global surgeons, as global citizens, we need to think about establishing some kind of an international norm of ethics, of conduct. And this is something we need to think about because also in the US, we have shortages of physicians and nurses and so on and so forth. So this is indeed, therefore, a global problem. And we all have to, therefore, be part of the solution by helping them and also helping ourselves together by creating some kind of a different thinking, if you will, than just letting this passive migration happen. Education is the other dimension that everybody needs to be aware of, and it speaks volumes. And as I said earlier, if poverty is a direct barrier to education, so #1 and #4 go together, and and if there's lack of education, this increases the likelihood of children being poor, not having clean access to water or sanitation, and then being sick and die early. And in fact, the amount of children that have no access to school is every year is increasing. And UNESCO has a study back in 2012 where they showed, of all kids who need to be in school but are not in school, more than half are in the sub-Saharan Africa. Imagine about that, how many millions they are. So as global citizens, therefore, we need to think about education. Without education, there is not going to be any improvement in whatever we want to do. And therefore, it is not only thinking about the education problem and doing something about it, but also think about educate the women. Because it has been shown again and again and again, the amount of impact and empowerment that you can get in communities is much, much greater. And unfortunately, between ages of 6 and 11 years, the majority of the kids that are out of school are girls. And so these are critical things to know about. And, I hope it gives you a little bit more dimension to the global thinking and understand when you participate in the work of global health, how all these things impact. It's not there for only the surgery we want to do. It is not only the patient we want to see and treat. I want to tell you now, just pivot a little bit to why I wanted to do global health, and also maybe go into how I started, how I failed, and also the lesson learned, because I think sharing my failure probably will help those of you who are at the beginning of global health, give you some direction in terms of not to do the same mistakes I did. For me, it was very simple. My why is I just wanted, to go from what you call a successful, academician to a citizen that causes or does some work that has some significance. And so this book meant a lot to me. It was really a transition for me. Once I have, gone through all the motions of, going to medical school in Italy and becoming a surgeon in the US and becoming a vascular surgeon at the University of Wisconsin and rising through the ranks. The success, the individual success absolutely was there. And therefore, for me, it was really more of a matter of what are the significant things in life for me. And that's how I got started. But maybe, I need to mention also, it gave me an opportunity to spend more time to see my mother by traveling to the global health. And so there was that conflict of interest also probably there, right? So that said, clearly my why was very clear. The more I got involved, the more addictive it got. There's so many people to help, so much impact you can do. You actually enjoy every single day you are on the field. It's not transactional. And you do actually the doctor you want to be. However, at the beginning, I was faced with a complete failure, and I'll tell you why. So when I went to Ethiopia to start this Global Health Partnership and visited the Department of Surgery, I saw so much of an issue they had from caring for the trauma patient. They did not have minimally invasive surgery. They didn't really have a structured way of taking care of cancer patients. So for me, it was very clear. These are things that I can help with. I can just connect them, bring them to my institution, give them some, formal training for a short period of time and work with them and build trauma, care, as well as minimal invasive laparoscopy kind of the work and also cancer focused, activities. And so I spent some resources. I got some grants locally and brought in a few surgeons from Ethiopia, and we had really a good, amount of time for them to spend here in Wisconsin. But subsequently, 6 months after they went back home, I did not hear anything. There was no movement, and there was no interest. My emails were not getting responded to. And, clearly, I was disappointed, but I was also motivated to really learn if there was a major failure from my side that I didn't pay attention to, and wanted to admit if there was a failure, correct if this was something correctable, and went to discuss with my colleagues in Ethiopia what happened. We had a plan. Why is it not working? And they were very honest enough to tell me, well, Girma, that was your plan. That was not our plan. And so that hit me because it was, yes, all my plan. I was trying to help, but I was also helping them developing their plan. And these are surgeons who do everything. And so one of them said, I can't only be a trauma surgeon. It's just, there's only 7 of us. And there is 5 million people in the city. How do you want me to be the trauma surgeon? And the other one is like, I can't just deal with only breast cancer. So in other words, they know the importance of what I was trying to say, but it was not timely. It was not something that was their priority. And therefore, we had to take a step back, think about this more, and go through a process of understanding, is this going to be something we're going to mutually beneficial? Because that is really what makes it long lasting. Is this something sustainable, or is the organization ready to do this? Is the Ministry of Health behind this plan? Do they have even a 5-year plan? Does this fit in there? And are we going to do is training workforce, or is this more infrastructure development? So you need to really go through a checklist and get it started and get started well. And with that, actually, we came across a principle called the twinning partnership principle. And this principle was developed, I don't know how many of you guys were old enough to know when the Eastern, countries, changed their ideologies and the wall came down. And as you all know, most of those countries from the East joined the Western European countries. And at that time, for a development model, they have this twinning partnership where the country from the West would adopt another country from the East and help them develop their infrastructure, their administrative infrastructure, their economic infrastructure, and so on and so forth. And that model really is, involves, all members in the decision-making process. It requires really a much wider, group of volunteers who participate. It requires a broader institutional support and so on and so forth. So we basically started with this, and we went step by step implementing that protocol. Identified, first of all, their priorities, identified their visionary leaders from the other side who really wanted to lead and be part of this undertaking. And we really developed shared vision and goals together. And guess what? Their first most important priority was developing emergency medicine programs, because the emergency department was a no man's zone in that hospital, in that university hospital, and they wanted to put some structure to it. And if your emergency department works, think about how the rest of your hospital will be actually a lot more efficient. And so with that, we got our work, cut out for us. We created a plan together, a plan that had input from everybody, including experts from the US, all the volunteers that were participating. We defined so many elements, how to communicate, how often do we communicate? Is it by phone? Is it by email? Is it both? Is it Skype? Is it, so, and then what are the activities we are going to do? What kind of calendar of events do we have? So we really spend every year 3 days to plan the year. And we come out with a document that outlines all the events that's going to happen during the year. And during this, planning process, we also adopted the accountability piece. Sometimes it's a couple of people accountable for what needs to be done. Sometimes it's the institution. Sometimes it's individuals from both parties. And so with that, the implementation became a lot more easier. We created a seamless process where we'll look at what do they have locally as a resource. How can we maximize that? We don't have to recreate everything. There might be some curricula already in place. How can we make it better? If we are going to create a curriculum that's new, we need to think about them owning it. So our role is going to be really helping them to develop it. Just give them the tools and the structures. And we really created a roster of volunteers who are dedicated to do this work over 5 years, meaning the same individuals going there again and again. It's so important because once they go once and twice and 3 times, they are familiar with the space, they are familiar with the culture, the friendship that they have already. And so for them, actually, the work becomes exponential rather than having a revolving door of volunteers that somebody who's new goes there for 2 weeks. The first week, you're learning where is what, and then only the second week is where you can produce something, but that will also be limited because you don't have much knowledge. And so we really made sure in this phase that we had dedicated core groups of volunteers, and those volunteers will go again and again, and the work actually became a lot more meaningful. We also had an opportunity to create a system where we would monitor what we do by creating some indicators. And in fact, in the mid-year, we'll get together to assess what we have done the past 6 months and see who failed and why did it fail, and what can we do to make this better. And we introduced, quality improvement program actually for the university, whereby the physicians would assess, where is their quality now and where do they want to get to. If you just take, for example, the emergency department, just in the first year, there were 12 quality improvement projects running at the same time, from making the triaging process easier to understanding the availability of emergency medicines in place, to trying to improve the quality of training for people to assess trauma patients, and so on and so forth. And so this became really, really a critical component of what we did. And with that, at the end of the year, we'll always get together, evaluate, and move on to a point where, after a certain amount of work that was done, successfully, publications started coming out. And, I can't tell you how many promotions happened because of this, both in our institution here in Wisconsin, as well as at the university in Ethiopia. And so this phases of starting partnership, developing partnership, and moving into subsequently disseminate best practices and results, both good and bad, was a very critical element. And I think for academic institutions, this is by far one of the most important achievements. Here's a list of things we just did in few years. We had a residency program in both adult and pediatric emergency medicine. We had, a brand new structured emergency medical services that never existed before. That included actually nurses that were being trained at the master's level to really run some of these emergency medicine centers, not only in the capital city, but even outside. We were able to use the same model and start a family medicine residency program, and more, be it the student education program, and one of our last results was vascular surgery fellowship program. People think vascular surgery is not needed on the continent, but to the contrary, it is really incredible the amount of vascular surgery need. You don't know it until you go and see and check it out, because you don't even know what kind of prevalence there is. And so we have been very successful using this kind of partnership. So just to summarize a little bit here, and most important lessons learned is, first of all, it is really also important not only to train people, but help them also fix their healthcare systems. If we are going to teach them that, the whole 9 yards about managing a trauma patient correctly, they need to also have some of the tools they need, to assess, and image, and, as trivial as it may sound, having a pulse oximeter, a blood pressure cuff, all those necessary equipments need to be there. I'm just, or you teach them how to do fast, but if you don't have an ultrasound, it's not going to work, right? So we really need to think that way, to just make them feel that what they have learned is being used and helping people. This is important also because of the migration that I mentioned earlier. When I did a survey of about 103 Ethiopian physicians who practice medicine in the US, the number one reason why they left the country is actually lack of professional development. And so this really, really, fits in nicely with what we have been talking about in terms of developing them. But once we develop them, they need to really have the tools they need. And it was very important that I learned early on that when we look at our US or Canadian or European colleagues, we are everywhere, but we don't even talk to one another. Sometimes you will be surprised if you go to Uganda at the Makerere University, you may find multiple departments from the same university who have not even known that they have partnerships in Uganda. And so it is really important to figure out who else is doing what I do or what I'm trying to do, who else is in my neighborhood here, and joining hands will actually amplify the success. And unfortunately, we really like the silos and we try to stay on our silos all the time. And it is critical that we bring our efforts together. It is also important to know who are the political players here and who can really make the work we do successful. And this is the Minister of Health from Ethiopia, and he's currently the Director General at WHO, Dr. Tedros, and he was absolutely a partner in all the work we are doing. And so having that political will on your side is very critical. If you allow me to pivot, spend 5 minutes on what we do in the same theme from the American College of Surgeons perspective, think about all the places our fellows are. And members are either as part of an NGO or as part of an institution with a global surgery program. We are everywhere. And when we are everywhere, our accomplishment is also going to be minimized, right? Because if I go to someplace in sub-Saharan Africa for 1 month out of a year, the 11 months I'm not there, they are on their own. So that continuity of change and improvement, the work you can do together is not going to be accomplished. So we are really spread thin. And so my goal was, I just moved through some of the slides a little bit to show you. My goal was really from that do good and feel good, we really wanted to create the surgical training center. How can we bring different institutions from the US to participate and build infrastructure in one place? But first I had to find a place where we can do this. And with the help of the Regional College of Surgeons in East Africa, we identified and selected one specific university hospital in southern Ethiopia. And subsequently from the US, we were able to recruit 13 institutions who wanted to take responsibility 1 month each. So if I say University of Wisconsin is responsible for the month of May, we make sure a couple of people or a person will be on the ground the entire month. And in our case, we had actually 2 individuals overlapping 2 weeks each as surgeons who are going to be there. And think about the resident that will be there benefiting from this. And having therefore that kind of a space where 13 institutions were participating, it gave us the opportunity to have a US surgeon, board certified, on the ground 24/7. Usually it was more than one because there will be other volunteers who want to be there as well. And this was basically by applying all those principles of partnerships I talked to you earlier about. We used exactly the same model. And we really created an environment where we could hold the participants all accountable. And also the responsibilities were clearly shared. We had the Ministry of Health from Ethiopia that was supporting transportation. The university locally was taking care of all the local arrangements, be it the guest house or transportation, and making sure the documentations are processed and putting you on the call schedule, on the lecture series, and so on and so forth. And Operation Giving Back was coordinating all these activities by having an annual meeting as well as a monthly meeting, and also keeping frequent Zoom getting-togethers. What did we do in a year? A lot of achievements. We had so many people visit the place and work clinically. They have been teaching, and research activities started. From a 0 research output, in a year time, we had 7, first case reports written out of that university. We developed a research training program that 20 individuals participating, and 8 are now actively doing research that we hope will be coming out soon. There has been morbidity and mortality conferences introduced, and basic laparoscopy that was non-existing was started actually in April 2019. Burn care assessment and education, trauma care, and telehealth, by partnering with industry. And we had actually 2 telehealth equipments that, some of our colleagues from New York and California would log in to sometimes run in the ICU with the one ICU physician that's out there. So the list is really long. This is not all. So we exponentially really achieved a lot of things. And in fact, there is already abstracts and papers accepted to different meetings here in the US. And our number from that 1 is this year going to 3. We are opening a second hub in Zambia. There is already 11 institutions that have signed up for this. And there is also a third one that's starting in Rwanda, which is going to be specifically subspecialty focused. And the subspecialties are going to be in trauma surgery, in cardiothoracic surgery, and plastic and maxillofacial. So I want to leave you with this quote from a student that actually traveled with us in the past, which really tells you how much impact it has for us from the US, for our students, for our young residents, for our young faculty. It is really, really a life-changing experience. It is something that, at some point, if you get the opportunity to travel, please take it. Go and visit and see how much value you can add, how many people you can help. And actually, it will change you more than what you think. And we are, from Operation Giving Back perspective, available to support and help any fellows. And for those of you, how you can get involved, just reach out to me. This is my email, gtefera@FACS. Our manager at Global Health is Natalie Bell. This is her email address. Write us. For residents, please join the RAS, be a member, and there is a global health work group that is really, really, really active. It is incredible the amount of work they do. For the junior faculty, RAS is also probably the place where you can start, but then there is a Young Fellows Association. And so this is going to be, I think, the future of our organization as well, I think. And it is really taking a lot of momentum within the college with participation and support from most of our leadership in general. So I will stop here and maybe leave some minutes for questions and answers. And I really, really appreciate being with you today. And I hope to stay connected. And if there is anything I can do, I welcome anytime an email or a phone call. Thank you.
Thanks so much, Dr. Tefera, and a virtual round of applause. Really, as we were kind of communicating offline here, we're just so grateful for all of the information that you're sharing and just experience. Wanted to recognize Dean Witt and our Executive Dean Strom. I know they have busy days, but we're so grateful that they were able to make it. I think y'all are still on.
Yeah, I'm here, Nia. Thank you so much. That was tremendous and really enjoyed it. And, thanks for inviting me as well. Not being a surgeon myself.
But you can enable the surgeons. Thank you for being here.
Absolutely. I'd love to support this group.
Hi, Dr. Tefera. It's Dave Shibata here. Thank you very much for joining us today under unusual circumstances as usual. So I appreciate it. Quick question for you. This is always something that we struggle with. Dr. Zalamea, Dr. Ferretti, and their team have been extraordinary in kind of building a global surgery institute, our institution, relatively quickly and quite successfully, and certainly take the lead of someone like yourself in the national leadership position. How do we reconcile what happens, say, in our environment here in Memphis, a very underserved area, very under-resourced area, and the criticisms that we sometimes get from, say, institutional leadership that, hey, why are we investing all this abroad? Maybe we should be doing stuff more locally. How do you approach that? How do you answer that, Dr. Tefera?
Thank you. That's a very important question. And as you know, in the US, there are areas that we call surgical deserts, right? So where there are no surgeons. It can be an inner city. It can be multiple communities actually outside the main cities. And there is, in the US, over 10 million people who have no access to surgery. So it's absolutely the right question. And I don't think it should be exclusive or exclusionary. I think both are important. And the issue that or the barriers we find is sometimes our local political and local malpractice related issue makes it harder. And but we have to advocate for it. And in fact, there is models of surgeons who provide a lot of care for inner city individuals who have no access. And there are, a few examples that we can actually refer you to that we actually promote on our Operation Giving Back website that can show you how to develop those kind of local programs. And I don't think this, global engagement has to be with at the cost of help that is needed in Memphis, and both should be done. And I really do think the local one should actually be easier than the global one. However, you need the partnerships with the city, with the hospital. So there are additional things you may have to do, but organizing those free access clinics has to really be part of the effort. And in fact, I personally have no excuses to tell here in Madison to say, we are only going abroad. I know there's a lot of interest from our residents' perspective, but the local piece, at least in our town, through a free access clinic is for most part covered because there is an organized structure. And so I think that model is what we should support. And it is going to require a little bit more dialogue and discussion with the health systems in the city. It should not be a burden for one versus the other. It really requires, like anything else, planning and including some leadership from the city. It is going to require probably even from higher level in the state. So this is how many places do it. There are individual surgeons, however, in places like San Diego, in Salt Lake City, in Utah, and also in Virginia and some other places where they have free clinics on weekends and on holidays. However, the hospitals have to agree to support with those patients to some degree to have surgeries if they need surgery. And so it is really something not only responsibility of the surgeon, but the community in general. And so, I would broaden that and, and not favor one versus the other. And the local challenges are more, for sure.
Thank you.
I just wanted to comment, Dr. Tefera, thank you so much for really a wonderful lecture. And thanks so much to Dr. Shibata and Dr. Zalamea for inviting me. I really appreciate it. And I very much enjoyed the talk. I can tell you that when I was chair of ENT, our outreach missions were one of the highlights of everything we did. And you really feel like you're making a difference. And I think many of the points that you raised were very salient. I also wanted to publicly congratulate Dr. Zalamea, Dr. Faracia, as well as Dr. Ostendalgo on the formation of their Center for Multicultural and Global Health, which was just announced, I believe it was last month. And that's really been just due to the incredible work led by that team and supported by Dr. Shibata that really has gotten that off the ground. And I'm pleased to say that under their leadership, we already have substantive collaborations for multicultural exchange with the University of the Negev, and then also working in Zambia. So I think many of the points that you raised will be very, very helpful as we solidify these efforts and grow these efforts. But we're very proud of our surgical leadership of these, brought these forward for our institutions so that we can help people not only here in Memphis, but around the world. So I really say thanks to all of our surgical leaders as well as you for your inspiring talk.
I just want to really add to that comment, the point that, it is really important to look also across our institutions to see who are the people who do works like us, and joining those, forces together will really make a huge sense. And most importantly, I think, to go back to what Dr. Shibata brought up at as a question, I think universities, large universities like ours, we need to, take this responsibility, about our local needs, right? The underserved communities. And we are in that time and era where we need to look at the marginalized, and, we can't, not do something about it. And I'm sorry about, about being a little bit more explicit about that, but even my institution here in Madison, until, all this movement, with Black Lives Matter and, and all the marches and so on and so forth, and, people were not tuned to understand and even ask the question about how many right around the corner here are not getting care, and how many around the corner are underserved, and so there has to be an investment, and I really do think this is a time and era where institutions, universities like ours, should invest and help those marginalized that don't get care, and it is a time to look out for those, and we, and this is the right time to ask those questions. But it comes with allocation of resources, and those resources sometimes are not only health related, right? Some of those are, our business practices, right? How are we, helping the businesses that are owned by the minority around the corner? Because this really gets to the bottom of the issue of the disparities that we see all around us, and therefore I think it's important for our large universities, to really look at this and make the investment. And if we don't do that now, it is going to really hurt us, more. I don't want to say in the future, it's already hurting, but it's going to hurt more. So.
Great, Nia. Any closing comments, Nia?
Just wanted to, again, just thank everybody for your engagement. Thank you, Dr. Tefera, for being nimble with all the changes with COVID-19 and being willing to join us virtually today. Just looking at the roster of the folks on the screens, we're just grateful that there's an interest and there's a dialogue. And lastly, that there's an opportunity. All that we do here in our institution is all about this community. And we certainly feel that today, and that's really only possible with incredible leadership. As we've said before, our incredible leadership with Dr. Shibata, Executive Dean Strom, Dean Witt, and thank you again, all of you. We will be sharing this on YouTube on our Global Surgery channel, and we'll send that out to Ms. Cynthia. And we look forward to continuing this this relationship. Dr. Tefera, you're not done with us yet. We will send you more questions and ask more advice. And we're just so grateful for the ongoing counsel that you've been giving us over the years.
Great, thanks, Nia. And so Dr. Tefera, on behalf of the department and the college, thank you again for joining us for your lecture. Certainly the kind of customary honorarium and commemorative plaque are certainly on their way. However, given that you can't join us here, we will bring a little bit of Memphis to you. So there is a shipment that is currently on its way that may arrive today with a sampling of Memphis delicacies, including some barbecue. So please enjoy that and think of us as you enjoy that, please. So thanks again. And Dr. Feliz, if you want to take over the rest of the administration here.